I'm what is called a clinical pharmacist. So we have different types of pharmacists at Terrebonne General. We have staff pharmacists, and those pharmacists are gonna do order entry, and they are going to prepare the IV medications and the chemotherapy. But then I'm also a staff pharmacist on the weekends at times, but after 5 years of working there, I worked my way up to where I'm a clinical pharmacist. And so what I do is just dig a little deeper into patients, and I have a patient list that I look at. My floor is usually medical patients and surgery patients. So I'm basically like opening each patient's chart, and I'm digging through and I'm seeing what I can do for that patient to progress them to the next level. So the next level may be home, the next level may be a nursing home, the next level may be rehab. And there are barriers that we have for these patients to get to that next level. All these barriers cost the hospital money, and then outcomes are not as good if the patient is in the hospital longer. So I'm gonna talk to you guys more about what I do for my patients, give you an overview of what a hospital pharmacist does. I'm gonna talk about adverse drug reactions, all this, and medication errors. All these things can prolong a patient's stay in a hospital. Survival of a patient in a hospital decreases the longer they are in the hospital, as well as the cost to the organization. So I hope that after the 50 minutes that I'm here, you guys are able to have a better understanding of how pharmacology plays into all of this and how important it is. All right, so like I said, I'm a clinical pharmacist. I'm also the antimicrobial stewardship lead for our hospital, and I'm gonna go in depth more about that. I'm also a Lean Six Sigma pharmacist. So Lean Six Sigma is just a process of where we take a problem and we dissect the problem and we see how we're gonna fix it. So I'm also that. If you ever hear of a Lean Six Sigma green belt, and some of you are, okay.
I am a green belt.
That was fun, right?
Yes.
So I'm just gonna talk to you guys about the basic, can we, the volume, right here?
Yes.
That's loud. Okay, so a pharmacist, the basic role of a pharmacist is to receive, review, interpret, and process orders. At our pharmacy, we process anywhere from 3,000 to 5,000 orders in every 24-hour period. We have, I want to say, 15 pharmacists on staff. We do a card exchange, which means that for a 24-hour period, we are supplying a patient with every medication, every IV piggyback that they're going to need. Talked about that. Our IV piggybacks are made in clean rooms now, and I'll show you guys a picture of that. We also provide TPNs, and what a TPN is just a IV form of nutrition for a patient that can't eat for an extended period of time. We supply night shift pharmacists and technicians. All right, so in a big function of what we do, we have the Mary Bird Perkins Cancer Center at Terrebonne General. So we have anywhere from 30 to 40 patients coming through in a day getting chemotherapy, and we have a pharmacist dedicated to that. And then clinical pharmacy services, which is essential for our patients and any patient. So we supply medication in a Pyxis. This is a Pyxis, y'all can't see. So this is a Pyxis cabinet. So a nurse is able to enter her credentials to get in, and in all these drawers there are medications. So it's secured. They have the medication when they need it. A lot of this medication that's in here is what we call narcotics. I think that you probably have talked about narcotic medications. It's very important that those are locked in cabinets. Narcotic medications a lot of times are emergency medications, or what we would call rescue. So a patient is in trouble, they can't breathe, a nurse is able to log into this Pyxis station and override a medication like a bronchodilator, like albuterol, to rescue that patient and allow them to breathe. The patient's having a seizure, so we have Versed or midazolam, a benzodiazepine, that will rescue the patient from the seizure. So those types of medications are locked in these cabinets. Opioids as well. Each patient has a patient profile, and the nurse is able to log in, see the patient, and every medication that the patient is on. So we make sure that every process is safe. An aspect of doing that is taking the human aspect out of it, because we're all human, we all make mistakes. So the last thing we want is for a nurse to be able to log into this Pyxis station and any cabinet open that she wants, because that's not keeping the patient safe and it's not keeping the nurse safe. The other, the big profile case right now is what happened with the nurse, and she gave the wrong medication. So when you read up what really happened, she overrode over 20 safety checks. And to me, that's mind-boggling, but it happens. So you have to take the human aspect out of treating a patient, and we do try to do that to our best ability, and the Pyxis station is one of those ways that we can do that. I think what she did was she was trying to get Versed to sedate the patient to have the procedure, and she was typing VER, she couldn't find that medication in the Pyxis station because it probably was under midazolam, which is the generic name, and instead she typed VE and she got vecuronium, which is a paralytic. So she paralyzed the patient couldn't breathe but couldn't say, I can't breathe. And nobody knew what happened. And so this is why medication safety is just so important. So if they had taken the human aspect out of it, then maybe this could have been prevented. So one of the things in that case that we do and we've been doing is all of our paralytics are locked in a cabinet, but also they have a bright red wrapper around the top. So you have to actively, like when you see that bright red wrapper that says caution paralytic and you unwrap it, like that kind of signals you to like, oh, this isn't the right medication because Versed doesn't have that top. So medication safety is huge. So also you can return and waste in there, and then to waste narcotics, and that's also a patient safety feature. We have this RX destroyer. So I'll just kind of talk about that a little. So did you guys talk about narcotics, one in particular called fentanyl? Kind of talked about that. So yeah. So fentanyl is a pain medication, and it's utilized outpatient as a patch. So what happens with a fentanyl patch is you take it off, it's usually on the back, you take it off the patient's back, and you close it, you fold it onto itself, and then you can put it in, usually, it used to be that you would put it in the garbage. Well, there was an adverse event where a 2-year-old ingested the patch. So now, all fentanyl patches are folded on themselves, and it's put in this RX destroyer, and all this is like a yucky mixture of whatever that if you drink it, you would get sick. So we destroy all of our narcotics in there. So we're gonna talk about narcotics. You guys talk about, so the one that we always think of is, morphine or codeine, and that is an opioid, and that's used to treat pain, or hydromorphone. So we'll we'll go back to narcotics a little bit later. This is just about drug information, and where I get all of my drug information is Micromedics are up to date. Things change all the time. Medicine, there's so much research that surrounds medication and how to treat a patient. It changes all the time. And we saw this a lot with COVID. You know, it was like it was like a battle zone. We first started treating COVID patients, and honestly, there wasn't a whole lot of research out there. We just kind of did what we thought the patient needed. And over time, there's research that has come out. We know what works, we know what doesn't work, and our patients are surviving. It's very rare now that you hear of a patient in the hospital dying of COVID. So Up to Date is one of those resources that is truly up to date. It is up to date on the latest research, and if you guys ever have access to this, especially if you're going into the medical field, it's such a great resource. I mean, even if you want to find out how to treat ear infection, you know, it's a great resource. So order writing is a big, it used to be a big deal, because it used to be the funny thing that the measure of how good you are as a pharmacist is if you can read a doctor's handwriting. And we just don't see that anymore. Everything is electronic, so that's great. But pharmacists really do have a knack for reading the prescriptions. Home medications, we deal with that. Get to the fun stuff. All right, so prevention of medication errors. So nurses do have a lot of jobs, very important jobs. They are a patient's advocate. They have the job of making sure that out of all these patients, I'm giving this patient the right medication. Before, we were on Epic, and Epic is our electronic medical record. Everything was paper chart. So imagine you have 6 patients. How hard it would be to make sure that you had the right medication or you had the right medication. And I can't, so many times a nurse would call and say, I accidentally gave the patient next door this patient's medication. So now, and that, of course that's a huge medical error, medication error. So now with the event of all the electronic medical records, each patient has their own name bracelet. So that patient's name bracelet is scanned, the medication is scanned, and the patient is administered the medication. So of course, with that too, we're taking the human aspect out of it. So this is just all things that we do to prevent medication errors. We inspect the medication, we constantly have technicians checking expiration dates monthly. We talk to the patients, you know, because in a hospital, lots of patients are on pain medication. Just because it's ordered doesn't mean that they should be given the pain medication. So you have to ask these patients, are you in pain? What level of pain are you in? They may not be in pain and you don't even have to give the medication. So we just chart the effects of the medication in the notes. Anytime a patient is given a new medication, a new class to them, it's very important to talk to the patient like a beta blocker. A beta blocker like metoprolol is given for blood pressure, is given for high heart rate. So it's important that before you give the medication to the patient, you have to tell that patient, look, you might get dizzy when you stand up. Things like that. You might feel like you have low blood pressure. You might feel like your pulse is low. Things like that, so that the patient understands the medication that they're being given. So in the pharmacy, we dispense a lot of high-risk medications. High-risk medications are chemotherapy, and the way that we protect our patients with chemotherapy and make sure that we decrease the incidence of medication errors is we do a double check. So we get the order, a pharmacist checks the order before they enter it. the order goes to the compounding pharmacist. The compounding pharmacist draws up all the medication, leaves the vials in the hood, and then another pharmacist checks to make sure that what was actually ordered is actually what was drawn up before it gets injected. So chemotherapy, very high risk. I mean, if you give chemotherapy to the wrong patient, it could be detrimental. Investigational medications, I don't know, have you guys heard of CIS or cardiovascular? Okay, so CIS is like world renowned. We have patients who fly in from all over the world to have procedures done in our cath lab because CIS is so cutting edge with the research that they do. A lot of times this involves investigational medications. So an investigational medication is, we think that this works, we've tested it, we wanna test it on you to see that it truly does work. So we do this a lot in our cath lab at Terrebonne General. IV potassium chloride. So potassium chloride is an electrolyte. In small doses, in normal doses, they could be used to prevent a patient from having a cardiac arrhythmia that could cause them death. So we treat our patients who have low potassium with IV potassium, but it's a high alert medication. You have to only give a certain amount of IV potassium to a patient. IV potassium is one of the medications that they use in the death penalty patients. So that's one of the drugs that they get, and at high doses it stops the patient's heart. So we want to make sure that we're giving the right amount of potassium to patients. Also, potassium burns. So you have these little old ladies with these little bitty veins, and they can't handle IV potassium. So we have to make sure, because it does burn, we have to make sure that it's given at certain concentrations in a bigger line. Some lines are like in the arm, some are in the neck. Essentially, you would want to give it in a central line, which would be in the neck. So opiates are also high-risk medications. Does anybody know, I don't know if y'all went through opiates yet, but does anybody know like the main side effect of an opiate? Like adverse reaction if you take too much. Well, so that is one, but in the short term, if a patient takes too many opiates, it causes respiratory depression. So a lot of patients, if they, heroin is an opiate. So patients overdose on heroin because they are trying to just get high, but they take too much. And so it causes respiratory depression and their heart stops beating. But it's also an opiate, so that's why a rescue drug for, you guys know what the rescue drug is for opiates? No? On the street you probably know it's called Narcan. So Narcan reverses opiates. So that is why for opiate overdose, you give Narcan. On the streets, the policemen give Narcan, and it's almost instant that these patients wake up. So it's pretty neat. And if somebody comes into our emergency room, really you don't have time to get a drug screen. So if somebody is coming in respiratory depression, they will give Narcan, and you'll be able to tell if that patient overdosed or not, because it's pretty instant that they wake up. And so, of course, our controlled substances like morphine, like hydromorphone, they're kept in locked boxes. They're kept in the Pixar's cabinet. Insulin. So, do you guys know what insulin is used for? Yeah, diabetes. So, we have in South Louisiana, we have We always have family gatherings, but we also have a lot of obesity and a lot of diabetes. So a consequence of having a patient on insulin is hypoglycemia. So you would think a low blood sugar is good, but it's not. There's some research that looked into the cost of one hypoglycemic event for a patient. And a hypoglycemic event is a blood sugar less than 60. So a normal patient like you guys are young and healthy. Your blood sugar is probably less than 100, which is perfect. These patients who are on insulin with diabetes in the hospital, we want to look for a blood sugar of 140 to 180. Really, anything below that, you are decreasing the positive outcomes for that patient. So, of course, we don't want to go higher because that's not good either. But there was studies that showed that not only does a hypoglycemic event decrease that patient's survival, it's going to increase their length of stay, and the cost to the organization is $7,000. So think about that. One hypoglycemic event. And concentrated electrolytes again. So chemotherapy, we talked about that. We do all of, I don't know if you guys go through chemotherapy. No. So chemotherapy is used to treat cancer. So this is the glove boxes that we work in. So they're fully gowned up because you don't want the pharmacist to be exposed to chemotherapy. A lot of patients that get chemotherapy, it drops their white blood count. If your white blood cells are low, then you can't fight off infection, and you get really, really, really sick. So if we're not protected while we're mixing chemotherapy, then we have a chance to get really, really sick. So this is all closed, and then it vents. There's a vent up there. It vents to the outside, to a filter. So we mix all chemotherapy needed for our Mary Bird Perkins Cancer Center. Approximately 40 patients on average per day. And each patient may have 3 to 4 chemotherapy items or IV piggybacks that they're getting. So it's pretty extensive. So some safety measures that we can take in order to decrease adverse events, increase medication safety, is we use this closed system device called, I'm going to have a picture, EquiShield, yeah. So whenever you are mixing any kind of drug, when you insert a needle into that vial, fumes are going to come out. And we don't want anybody to be exposed to these fumes, but those droplets and the fumes are also going to get all over the syringe, all over the IV bag. So that's exposing yourself, exposing the transporter, exposing the nurse. So these millionaires now, probably billionaires, came up with what's called a closed system transfer device. And so this is all closed. This is closed. So, and there was extensive testing that shows that no fumes whatsoever escape the vial, the bag, the syringe. So it probably adds about $15 per dose that we don't get back. So somebody who invented this is on an island somewhere, but it's keeping everybody safe. And it's mandated by the government. Dose verifying, we talked about that. The double check is so important. And not everybody, everybody makes mistakes. And whenever you're in the medical field, whether you're a doctor, you're a nurse, you're a pharmacist, I promise you will make a mistake. So I always remember I made 2 mistakes that kept me up at night. One of those mistakes was I saw what I thought I should see. So when I checked a chemotherapy, I thought I saw what I wanted to see, but that's not what I saw. And the So it ended up being fine, but it's just so important in the medical field to always be diligent about medication safety. So since then, you can't insert any medication into the IV bag without having the syringe and the vial. So before you even insert that medication into the IV bag, another pharmacist has to check it. So that's important because had I not made that mistake, somebody else would have made it. And so since I did, we were able to put a process in place to take the human aspect out of it. All right, so dose verifying, we talked about that. And what's important, and I want to reiterate or bring this to light, is dose verifying. So just because a doctor writes it doesn't mean it's correct. And so, you know, just because we don't just verify what a doctor enters, because they're human as well. So a lot of conversations go on all day long with, this patient weighs this much, the calculations aren't coming out right, and we work very well with our physicians, and they'll say, okay, Lacey, you're right. Can you change the order for me? So that was a shift from many years ago, where anything the doctor wanted, they got. And is that your background?
Mm.
Yeah.
Well, I worked in the hospital for 20 years, so.
So you know.
Mm-hmm.
And we do. We have older pharmacists, seasoned, brilliant pharmacists that are reluctant to call a doctor because you just didn't do that. You didn't question them. But we do now. You know, we are the drug experts, and we work very closely with our physicians. They learn from us. I have learned so much from them over the years. So, and it's all about patient safety. It's all about doing what's right for the patient. Okay, so pharmacist lab work. If you mix chemotherapy, you have, you're at risk. So every 2 years, our pharmacists have to do blood work and provide urine samples. And they're looking for different things that would alert them to, you've been exposed to chemotherapy when you were mixing it. You may have a low white blood count, you may have a low blood count in general, things like that. So, looking at this on. So this isn't that big, but controlled substances, we're gonna talk about that. So controlled substances are put into schedules. It used to be legends, but it's schedules. So the higher the number, the lower the abuse potential. So like Schedule 0 would be street drugs. So that's drugs like, I don't even know if they have it, like acid. I don't even know if that's even bath salts, I guess. I don't know. Like, so Schedule 0 is not something that anybody can prescribe, but it is highly, highly addictive. That's not something that you're gonna find in the hospital, that's street drugs. Schedule 1, this is heroin, ecstasy, so this is, yeah, Schedule 1. Schedule 2 is what you're gonna find in the hospital. So these are our highest abuse potential. So these are like morphine, hydromorphone, I'm sure that those are medications that you've heard about. Morphine is utilized a lot post-operative. So for post-op pain, we give IV morphine. A lot of times those patients can't eat. They're just coming back from surgery. We try to limit our use of narcotics, even in the hospital, because the abuse potential is so high that it's not good for the patient. Narcotics like morphine slow the gut down. So what happens is these patients have trouble going to the bathroom. That can cause a lot of other problems that decreases their ability to work with rehab or do physical therapy. It increases their length of stay. So we do not every now and then you'll see a patient on IV opioids like morphine or hydromorphone, but, not often. Schedule 3, that would be like Tylenol with codeine, has a lesser abuse potential. Benzodiazepines like Ativan or midazolam, like that we use those a lot for seizures. Sometimes patients come in and they just having convulsions and we can't stop them. We use in the field on the in the ambulance they use those drugs. And then Schedule 5, the lowest abuse potential, Phenergan with codeine. We use that for coughing. So what is an adverse drug reaction? I know I've talked about this a lot. And the WHO definition, or the World Health Organization definition, is defined as a response to a drug that is noxious and unintended, and that occurs at doses used in man for prophylaxis, diagnosis, and therapy for modification of physiological function. So what does that mean? So it's just an unintended effect of a drug. Every drug has adverse effects. I mean, they just do. But what we're talking about is something that actually causes the patient harm by taking a drug that was prescribed. So like low blood sugar. Blood glucose less than 60 is an adverse event. Giving a patient morphine and they end up going into respiratory distress. That's an adverse drug reaction. And those have to be reported and they're tracked in trends. So when you're talking about controlled substances and adverse events, things that we can do to decrease the likelihood that this is going to happen, we can dispense and seal those vials or syringes. And so what that means is if the dose of the morphine is 2 milligrams, then we buy 2 milligram vials instead of 10 milligram vials, because truly there's nothing that's going to stop that nurse for to give 10 milligrams versus the 2. And so we're taking the human aspect out of it. So if you want to give 10 milligrams of morphine, then that's going to be 5 vials. And that's going to like make that nurse think this probably is too much medication. Things like that. We lock it in the Pyxis station. Patients who are on opioids can be on continuous oxygen monitoring. So we monitor their oxygen, and there's an alert that goes to the front desk to say this patient's oxygen level is too low. Reversal agent is Narcan, and we track and trend our narcotic usage, things like that. Insulin. So insulin is a big one. It's used to control blood glucose in patients with diabetes. It's a high alert medication. The high alert medication of insulin, a nurse draws it up, but another nurse has to verify that that's actually the dose that they intended to give. Normal blood glucose range is 140 to 180, and adverse events, hypoglycemia. A big stop sign for us clinical pharmacists is a blood glucose of 100. So when we see 100, that's our stop sign to say we need to alert the doctor and we need to change the insulin therapy. Because we know that doctors have 50 patients to look at. So if we can alert them of things like this to prevent the blood glucose from going lower, then we prevented an event. Save the organization $7,000. Decrease the length of stay for the patient. When the blood glucose is less than 60, we treat the patient with oral glucose tabs or IV dextrose. So we have a total hypoglycemia team that looks at this. They review the patients on insulin daily and make recommendations if necessary. So if a patient comes in on insulin, we know, you guys know diabetics, anybody? So how do they eat at home? What do they eat? Whatever they want? Yeah, they do. So especially, not everybody, but in South Louisiana, they eat whatever they want and they add more insulin. That's just what they do. So they're on a certain insulin regimen at home. What happens in the hospital? The dietitian comes along and it's like, no more fried chicken for you. So they're eating grilled chicken and green beans. So what do you think is going to happen if they're on the same amount of insulin and they're not eating the fried chicken and the biscuits and the dessert? Their blood sugar is going to drop because they're eating like they should be eating. So what we do as pharmacists, when we get that order, Miss So-and-so has been admitted to the hospital, she's on this much insulin a day. They want to just restart that much insulin. And we know if we do, that patient's going to have a blood sugar of 30. So we don't. We call them and we intervene and we say we need a cut based on American Diabetes Association recommendations. We need to decrease this patient's insulin by 25 to 50% to prevent an adverse drug reaction. So that's what we do. Takes a lot of time and a lot of our day, but that's what we do. Because if we didn't do that, then we'd have all these patients with their blood sugar going up and down, and we would be reversing, we would be given dextrose, and they just don't feel good when their blood sugar is not controlled, and they don't heal well. And so that's the main reason why we do this, for the safety and the well-being of the patient. So there's a bi-weekly committee that meets to review the events, constantly providing nursing education. Anybody gonna be a nurse here? No? Okay. I don't know if you guys have experienced this or know anybody, but we have an extreme shortage of nurses. Post-COVID, nurses went to travel, do all these other kind of things, and I don't blame them, but we have an extreme shortage of nursing, which causes the need to educate constantly, because we have travel nurses and their policies where they were, it's different from ours, so this hypoglycemia team is constantly educating our new nurses. So we have to report any hypoglycemic events less than 50 to the hospital improvement network. And so the big picture is we're compared to our peers. So we do all these things, and at the end of the day, we're compared to our peers. So if we have issues or we're not where our peers are, then it's not a good thing, and reimbursement is decreased. Antibiotics, so that is my love, antibiotics. So that's what I do all day long. So antibiotics are used to treat an infection in your body caused by bacteria, not viruses. So the big thing is, you go to the doctor, and it used to be that you had a viral infection and they knew it was viral, but they were going to give you antibiotics, they were going to give you a steroid shot, breathing treatment, whatever, because that's what people wanted. Like, we don't go to the doctor and leave with them just saying it's viral, it's got to run its course. Used to be that people would be very upset with that. But now the push is overusing antibiotics is not good, and we're going to go over why. So adverse effects associated with antibiotic use, renal failure, we see this with certain combinations in the hospital. Vancomycin is one of them. Antibiotic resistance is very scary. Rash, GI upset, and Clostridium difficile, which is also very scary. So I am the lead for the antibiotic stewardship team. So why antibiotic stewardship in a hospital? So this is just something that I found. It said superbugs, these are our babies. Now they have body piercings and anger. So overuse of antibiotics causes these superbugs, and there's not many new antibiotics that come out every year. Not many at all. So you get to the point, if you're for a sick patient where you just keep on getting antibiotics thrown at you, there will come a point in time where there's nothing that can help you. So this is why we have to be good stewards of antibiotics. And it starts early on. It starts in the outpatient setting where if you have a virus, you don't need antibiotics. Because guess what? When you have that bacterial infection where you really need the antibiotics, they won't work. Your body's gonna say, oh, I've seen that drug before. I know what to do. And the antibiotics won't work. Billions of money is spent annually on antibiotics in the US. So 2 million antibiotic-resistant germs cause more than 2 million illnesses and at least 23,000 deaths each year in the US. So that's crazy. So this is just a quote from 2018. The last decade has seen the inexorable proliferation of a host of antibiotic-resistant bacteria, and this is 2008, or bad bugs, not just MRSA. I think we probably all heard about MRSA. But other insidious players as well. For these bacteria, the pipeline is verging on empty, which means that there are no drugs coming through the pipeline to treat these medications. What do you do when you're faced with an infection with a very sick patient and you get a lab report back and every single drug is resistant? And that is a reality, and that happens to us. This is a major blooming public health crisis. So essentially, this is the reason for antibiotic stewardship. So we have a team of a physician, clinical pharmacist with IV training, which is myself, an infection preventionist, quality improvement people, lab, information technology, and nursing. So these all make up the team. So things that we look at, this is the items that we're calling our doctors every day. Antibiotic de-escalation. So my patient is on day 3 of Rocephin, which is an antibiotic for a UTI, a urinary tract infection. But the urine culture came back, no growth. So it's my job to call the doctor and say we need to stop this antibiotic. Protected antimicrobials. So we have what we call the big guns. So like these drugs are a list of 7 antimicrobials that we want to reserve for the sickest of the sick. So when we get that everything's resistant but this drug, we know that it should work. So we look at those. IV to PO, once the patients are eating, we transition them from oral medications, IV medications to oral. And what does that do? That allows the patient to go home sooner. So we're progressing the patient to that next level. We do extended infusion antibiotics. We dose all. So anytime a patient has that MRSA infection and they want to use vancomycin, because that's the drug of choice, they consult myself or someone else on my clinical team, and we dose the vancomycin or the aminoglycoside. 10 minutes? Okay. I don't know how far we talked about that. So I just wanted to show you guys where we started and how we measure antibiotic stewardship. And so this is us. So that's where we started. And this is other hospitals. So we compared ourselves to our peers, and that's where we were. And this is where we are now. So we've put a lot of things in place to make a difference and to help our patients. So anybody ever heard of C. diff, Clostridium difficile? Very serious, very serious. We had so I'll tell you that, but it's a bacteria that causes diarrhea and colitis. It's very contagious. It makes patients very ill. It is a consequence of overuse of antibiotics. It's estimated to cause almost 500,000 infections in the US each year. 1 in 6 patients who get it will get it again in the subsequent 2 to 8 weeks. Ultimately, some patients do do die of C. diff because we just run out of treatment options. We try a list of 3 drugs. When that doesn't work, they have to get what's called a fecal transplant. And it's actually transplanting healthy fecal matter into a sick patient. And we've had to do that at our hospital as a consequence of overuse of antibiotics. So these are just the risk factors. Antibiotic exposure is number 1. Older age, recent hospital stay, weakened immune system, and previous history. So what are we doing at Terrebonne General? We instituted a decision tree. So the nurses have a decision-making diagram, and we track the number of tests. We reject foreign stool, so this is our testing curve. All right, so medication safety, I'm gonna quickly go over this. This problem is expanding with the aging population and growing number of prescription medications. The patients that come into our hospital that are elderly, they bring their own medications, and it's like a bag full, unfortunately. As patients age, they're much more likely to be prescribed multiple medications, increasing the risk of drug interactions, mix-ups, and side effects. So who is at risk from medication problems? Seniors who live alone, patients who take 3 or more medications, patients who have memory problems, patients who get prescriptions from more than one doctor, or fill medications at more than one pharmacy. And this used to be a big problem, and it's called polypharmacy, where a lot of times it involved scheduled medications. You know, they go to one doctor to prescribe pain medication, and then they go to another doctor to get more pain medication. But now there's a national registry. So anytime a patient is prescribed pain medication, it goes into the registry. And all these physicians, before they prescribe pain medication, have to log in. So we're actually, the patients aren't getting what they want, but we're protecting them. All right, ways to reduce medication safety. Take medication as prescribed. We had one event, so whenever a patient comes into the hospital, we don't allow them to take their own medication. So if they come in with their suitcase of medication, we ask someone to take it home, or we take it in the pharmacy. We had a situation one time where a man was having chest pain, and we gave him, it's called nitroglycerin, for the chest pain. Well, it resolved, and then we hear code blue, and it was the same room. And I was like, oh gosh, like we just came out of that room, what happened? He took his own nitroglycerin as well. So he ended up with a heart attack because he did that. So medication safety is the utmost important, especially in the hospital. There are 2 common types of medication interactions. Drug-drug interactions or food-drug interactions. And because we have an electronic medical record, anytime we try to enter a medication, it pops up if there's a drug reaction or a food reaction. So the ones that we aren't like always aware of, they'll pop up, so we'll know. Medication safety at home. Do y'all have any questions while
Anybody have any questions?
No?
I do.
Okay.
So, you had talked about the Narcan, that if a patient comes in the emergency room and y'all don't know what it is, you give them Narcan. What if the person isn't overdosing? What happens then with the Narcan?
So nothing. It won't do anything, and the patient is going to remain unresponsive. So at that point, you know that it's probably not opioids. They may have to intubate the patient. And then at that point, we could stabilize the patient and do lab work. But the Narcan is just so quick, and the opioid crisis is so bad, that when somebody comes in and, you know, if it's an elderly patient, then they may not Narcan that patient, but if it's a young patient and nobody knows what happened, they're gonna get Narcan. A lot of times they wake up angry. But, yeah. Any other one?
Anybody?
I hope it's interesting. It's a day in the life of a pharmacist.
What's interesting to me. I hope it's interesting.
Always read and follow the drug fact labels on packaging. And, you know, at home, okay.
So you said that medication is changing like all the time and everything, so is there certain like classes or continued education that pharmacists have to take to keep that up?
We do, yes. So every year, we have to have 21 hours of continuing education. And we can pick anything. Like I like to pick antimicrobials because that's what I'm interested in, or new treatment guidelines for C. diff or pneumonia. But yes, we do have to do continuing education, and a big part of that is sterile compounding now, because you have to make sure that these IV antibiotics are sterile, which means that they don't have bacteria in them that you're injecting into the patient. So we are required to do an hour of sterile compounding.
Another question about the chemotherapy. So when my husband was receiving chemotherapy, we were in a big room. Everybody was getting it. How is it that, you know, you were talking about the airborne and so forth, but how is that okay?
So it wasn't, you know, and so with the environment and all these environmentalists now, things are coming to light, and it was nothing to even mix chemo on a table, you know, and nobody really thought about the harm that you're doing to yourself, to the nurse, to the transporter of the chemotherapy. So now with these completely closed systems, everyone is protected. The only person that gets the medication is who it was intended for. It's like, why did we not think of this before? But 1 minute, okay. Do y'all have any questions? Oh, we were done. Medication disposal. Any of you guys know anybody that has medication that they want to dispose of? We do have a disposal bin at Terrebonne General.
Yeah, don't flush it.
Do not flush it, yeah. Because that's a whole nother, you know, we can't put drugs down the sink anymore. The EPA is all over all that, so.
Thank you
Anyway,
so much,
you're
Doctor.
welcome.
We really appreciate it. Very good. Okay, quiz is on Wednesday. I hope you took notes. PowerPoint is on Moodle for our presentation. So, and I'm going to, hopefully this video